Hello, everyone. I'm Richard Conway reporting for Room Now from ACR 2024. I'm here to talk to you today about a study presented in the RA-ILD abstract session on Saturday. This was study abstract 802 from Gregory McDermott and Jeff Sparks' group. This was the SAIL RA study, it's a multi-center prospective study of patients with early rheumatoid arthritis. So less than 2 years of disease on recruitment to the study. There are 172 patients in the present analysis. And the interest of this particular presentation was looking at lung disease. And first things, the numbers with lung disease were quite interesting. So 16% of these patients with early rheumatoid arthritis had RA lung disease. Now that is kind of a broad term and it included interstitial lung disease, emphysema, and bronchiectasis. And perhaps one could argue that the second two of those could be rheumatoid related, but could also be related to other things. But it's still a relatively high number. And when they looked at just interstitial lung disease, 11% of patients had interstitial lung disease. Now, that is a high number compared to certainly some of the more revisionist estimates of how many patients with rheumatoid arthritis get interstitial lung disease. And do remember, again, this is patients with early rheumatoid. So this is early on in the disease course. Potentially later on, even more of these patients will have interstitial lung disease. So they went and looked and analyzed with multivariable analysis about what predictors there might be of patients who do get lung disease. And for rheumatoid lung disease, so the three things, the interstitial lung disease, emphysema, bronchiectasis, two things we know about. So age and being male. So about twice the risk with increasing age, 4 times the risk if you are male. And then the one which I find really interesting, moderate to high disease activity. 4.89 was the risk with that. It got even more interesting when they looked at interstitial lung disease, and in that alone, so interstitial lung disease alone, the moderate to high disease activity, the number was 6.17 for having moderate to high disease activity. So this suggests a couple of things to me. It does seem that disease activity is really important in the development of interstitial lung disease in rheumatoid arthritis. It suggests that maybe there is kind of an amplification of this window of opportunity concept that we have in rheumatoid for these patients. And it's even more important to really aggressively treat patients who might be falling into these risk groups at the start to prevent the development of interstitial lung disease. And then the thing that I know everybody is waiting for me to say, the ACR guidelines, our recent ACR ILD guidelines, for rheumatoid arthritis ILD, they recommend as their first-line treatment options agents that have either very limited effect on disease activity or not as good as other agents we have on disease activity, so especially mycophenolate mofetil, azathioprine. And this is another piece of evidence and something in support of what I have said from the start, and that really the first thing we should be doing when we're trying to treat people who have rheumatoid interstitial lung disease is controlling their disease activity with whatever agent we need to do that. And then we can worry about what may or may not be better from the limited evidence we have for the interstitial lung disease itself. So I've been Richard P.A. Conway on Twitter, and follow Room Now for all the updates from ACR 2024.